Hey everybody, it's Nick Maynard with Emergency Learning Services again. I just got back from a run with my dog Oliver, who's over here taking a nap now. And I was thinking about the presentation that I just gave at my EMS agency and the chest pain evaluation protocol that I discussed with them. And I just wanted to share a quick version with you, as it's a very simple chest pain evaluation tool. 4 questions and scientifically backed, and you can figure out if someone's having an MI or not with pretty high certainty. With that, I just want to go ahead and jump right into it so I can give you a quick down and dirty on the 4 Ps. And like I just said, this is all about chest pain evaluation. I use it in the pre-hospital setting. I think it would work really well in just about any setting that you wanted to use it for. Emergency medicine, family medicine, it doesn't matter. I think that you'll see, I think I'll prove to you that scientifically this makes great sense. So the 4 Ps of chest pain, and it's basically 4 questions you can ask yourself / the patient. Is it palpable? Now, being palpable, that means, if I push on it, can I increase the pain, or is that what can cause the pain? And sometimes, that's pretty obvious. Sometimes you really have to mash around, but that's the first question. The next question is it positional? Meaning, does it only hurt in a certain position, or can a certain position make it better? With acute coronary syndrome, this is not going to be the case. Question number 3, is it possibly pleuritic? That means, is it associated with a cough? Have they had pneumonia? Do they have a cold? This right here just gives you an indication that there may be a different cause to their chest pain. And lastly, is it producible? Now, I get a lot of questions about how aren't some of these similar. Well, the thing about it is, something being producible could mean that it happens when they stand up. It could happen when they wiggle their big toe. You name it. Whereas if it's palpable, it's all about actually putting your hands on there and pushing on it. And if it's positional, it's all about, does something make it better? Does it only hurt if I lay back? Does it only happen if I'm sitting up? So some of these things do overlap, but everything you got to remember is on a continuum. Now let's take a look at why does this make a difference. Well, and to do that, I'm going to switch colors here for just a second, and I want to talk about the different symptoms that are very common. And as I start to write these out, I want you to think about which symptoms of an MI or a STEMI you would consider to be the most important. You've got nausea and vomiting. You've got diaphoresis or sweating. You got left arm radiation. You've got radiation to both arms or shoulders. And you have radiation just to the right arm or shoulder. All right. I just want you to take a quick second, pause the video if you need to, and think about which one of these you think is the most important. For nausea and vomiting, let me switch colors one more time. We're going to use some predictable factors known as likelihood ratios. So a ratio of 1 means it's neutral, no increase or decrease in likelihood. Greater than 1 is an increase in likelihood, and less than 1 is a decrease in likelihood. For nausea and vomiting, it's 1.9 times more likely. For diaphoresis, it's 2 times more likely. Left arm radiation is 2.3 times more likely. Radiation to both arms or shoulders is 4.1 times more likely. You see a quick big jump there that might surprise you. And radiation to the right arm or shoulder is 4.7 times more likely. That's pretty big. Now, you might be wondering, well, what the heck does that have to do with the 4 Ps? Well, let's go back up there and look at that. So now using the same idea, we can talk about things that make it less likely. Well, something being positional has a likelihood ratio 0.3. Something being described as pleuritic gives it a 0.2 likelihood ratio. Something being palpable gives it a 0.3 likelihood ratio. And being producible, that's a little bit harder to quantify, but if something is producible, that definitely points away from acute coronary syndrome. And when I say producible, I mean producible right now by doing a specific action, not, if they go for a jog and their chest is hurting. Well, I mean, that might be cardiac related, but that we're talking about acute coronary syndrome mostly here. And producibility is definitely a negative predicting factor. I just there hadn't been a study to produce the exact number for this particular factor. But this is the 4 Ps that I like to use. And going through these, you can see, just looking at the numbers, and all these numbers were produced through a variety of studies. If you answer yes to at least one, up to all 4 of these questions right here, the likelihood that they're experiencing acute coronary syndrome is very low. That doesn't mean it's impossible. Of course, we want to err on the side of caution, but again, if you go through these 4 Ps, this is a very quick way, prior to even acquiring a 12 lead or as you're acquiring a 12 lead, to go ahead and determine what you think the likelihood of someone having an MI is. Now, just go out there and give it a try. If you work in medicine, go out there and give it a try and see what you think. Thanks for listening, and consider subscribing.